Welcome again to this fourth webinar in the Nutrition Nuggets educational series. If I ask you to note your name and country in the chat, please, and we'll start shortly. So what we'll do is we'll off the cameras for all the videos and mute all except the presenters during the presentation. If you could pop your questions in the chat, or you wait until the end and you can ask your question directly. Once the presentation is finished, is over, we will give you the opportunity to on your cameras to engage in discussion. We'll give it 1 more minute and over to you, Peter. If you introduce yourself as you start, yeah, 1 more minute. Thank you. Okay, we are ready. It's 12:05 or 1:05 in Central Europe. Okay, welcome. We'll hand over the mic to the presenting team and we'll allow you to introduce yourself. Thank you very much. Enjoy.
Thank you very much, Mary, and everyone for joining us today. My name is Peter McCarthy and I'm a haematology consultant working here as part of the team at the National Children's Cancer Service at Children's Health Ireland in Dublin. And thank you very much for the opportunity to be able to speak as part of the MDT today around overnutrition and paediatric malignancies. So I'm the lucky one to get us started just with a brief introduction, I suppose, and maybe to set the scene about why this is becoming more of a prevalent issue within pediatric cancer. So I suppose historically malnutrition was often the primary concern while young patients were undergoing treatment for cancer. However, that concern has really been turned on its head, with between 20 to 40% of pediatric cancer patients now experiencing weight gain during treatment. There are a number of different factors contributing to this, some of which will be discussed in much more detail by some of my colleagues over the next few minutes, including improved supportive care, the use of corticosteroids, and the reduction in physical activity of patients while undergoing treatment. And I suppose it's important to be aware of the historical perspective in relation to what our primary concern was and what the focus would have traditionally been on in terms of ensuring sufficient caloric intake, and that we were willing to trade a lot of potential toxicity and side effects from the treatment, given that the overall priority and goal was ensuring survival from the patient's cancer diagnosis. Fortunately, over the last number of years, given the improvements we have seen in overall survival and improvements we have seen in treatments that are now available to young people with cancer, we have begun to be able to shift our focus from that being purely on survival, but beginning to look at quality of survivorship as well. We've also begun to see more and more a concern around overnutrition in the cancer treatment period. This leads to excessive weight gain, metabolic complications, and long-term health impacts, which I will speak about shortly. There are a number of cancer types that are particularly at risk for this phenomenon or this problem. So the most common cancer in children and young people is ALL, and indeed this is one of the highest risk groups for gaining weight during treatment, with approximately 40 to 60% of patients gaining excessive weight during their treatment. This is due to prolonged corticosteroid therapy both throughout their treatment and also the impact of potential CNS-directed treatment. The treatment for ALL, as I'm sure you're all very familiar with, is very long, lasting 2-3 years potentially, and this increases the cumulative risk of weight gain over this very long period of time. The next big group of patients that this is a challenge in are those with CNS tumors, and there are a number of different risk factors that can contribute to this, including cranial radiation as part of their treatment, or subsequently the impact on the hypothalamic pituitary axis, which can lead to weight gain as well, with approximately 30 to 50% of patients with CNS tumors developing obesity after their treatment. This can be due to the hormonal disruption, which I've already referenced, and also appetite regulation changes. Looking at a more moderately risk group, then that's those patients with Hodgkin lymphoma, with approximately 1/4 to 1/3 of patients experiencing weight gain during their treatment. And again, this is down to the use of corticosteroids in the protocols and also thankfully improved treatment outcomes. The contributing factors to this challenge could be mainly looked at in two ways, I suppose: treatment-related factors and psychosocial factors. So some of the treatment-related factors are to do with the particular types of medications that we administer to patients. So steroids I've mentioned repeatedly already because they are so relevant when we're talking about this patient population, given that they increase patients' appetites, they directly alter their metabolism and can also lead to fluid retention. Chemotherapy can have an impact on patients' eating and drinking abilities due to the impact of nausea on patients, sometimes leading to a preference for higher calorie foods. Radiation therapy can damage the hypothalamus in patients with CNS tumors or those requiring radiation in that area. And treatment itself can potentially reduce physical activity due to fatigue, hospitalization, and activity restrictions for patients with central lines, for example. There are also a number of psychosocial factors, which will be discussed in much more detail by some of my colleagues. They include family dynamics, using food as comfort, altered eating patterns, social isolation during treatment, and anxiety and depression, potentially impacting on patients' eating patterns. So why does this matter? Why do we care about overnutrition in young people during cancer therapy, given that the concern previously was around malnutrition? Well, it can have a number of significant health impacts in patients, both short-term and long-term. So the short-term metabolic consequences include insulin resistance, dyslipidemia, hypertension, and fatty liver disease. There are also treatment-related consequences. So it can impact on patients' ability to heal following a wound. It also increases their infection risk, potentially delaying further therapy. It can potentially impact on medication efficacy due to third spacing or having to dose patients based on ideal body weight as opposed to actual body weight. And there's also the psychological impact on patients, seeing the direct consequences of the treatment that we're having to give on their bodies and how that may impact their compliance with some of the therapy that they may need. There are also longer-term health impacts. And when we compare this patient cohort to the general population, we know already that there's a significantly increased risk of cardiovascular disease in long-term survivors of childhood cancer. This is particularly marked in patients who are CNS tumor survivors. There's a 4 to 6 times increased risk of osteoporosis, likely due to corticosteroid and radiation effects. There's a 3 to 7 times increased risk of metabolic syndrome being developed, which can affect up to a third of all survivors. And there's 2 to 3 times an increased risk of secondary cancers. Now, that's not just down to the increase of weight seen during treatment, but it can potentially be implicated in relation to some obesity-related malignancies that can develop in later life. These longer-term impacts impact multiple different body systems. From the cardiovascular system, where we see increased incidence of heart disease and raised blood pressure. From an endocrine point of view, some of the hormone deficiencies I've already referenced and development of diabetes in later life. Skeletal issues such as osteoporosis, leading an increased risk of fractures. Respiratory impact in relation to reduction in lung function longer term. Reproductivity can also be affected. We know that patients who have an increased BMI can sometimes have increased issues with fertility or the development of PCOS. And then the metabolic concerns around insulin resistance and dyslipidemia. All of which shows that this is really important. And really, it's about trying to prevent this from happening in the first place. And if it does begin to occur, what can we do about it in the early stages to try and support patients and families through and following their treatment? And hopefully, as you'll see over the next 30 to 40 minutes, that a multidisciplinary team approach here is really key. And this is not something which can be managed in isolation by only one member of the team. During treatment, we can do things such as nutritional counseling, encouraging appropriate physical activity, considering the judicious use of steroids if possible, and educating patients and families in relation to the risks of overnutrition. And then the post-treatment period then, it's about continuing to regularly monitor for challenges, encouraging and intervening with lifestyle interventions early if they're needed, considering the role of medical management if and when it's appropriate in terms of managing the potential consequences and side effects of overnutrition. And really, I suppose, and most importantly, it's about involving your MDT early and often in trying to help and support these patients and families. So I'm very glad now to hand over to my colleague Amanda, who's going to take you through the next section.
Thank you very much, Peter. My name is Amanda and I'm the dietitian here on the hematology team. So I'm not sure if anyone is familiar with this. It's the Foresight obesity map. I just thought it would be a really good place to start. Basically, it's a very good visual, I suppose, highlighting just the amount of factors that can influence a person's weight. I suppose very individual. So psychological, genetics, right up to, I suppose, food production and government policies as well. So, you know, this is, it's a difficult thing to manage. It's not just, you know, a review by the dietitian and then, you know, things are all sorted. So diagnosing pediatric overnutrition, I know this has been discussed before, but overnutrition does fall into that category, I suppose, of malnutrition, of which our patients are at high risk of. And even at baseline, so before patients even begin their treatment, 1 in 5 children living in Ireland, and the stats are the same across Europe and in the UK, are overweight or obese. So I suppose bearing in mind then the risk they're at of developing overweight or obesity during treatment, it's quite difficult when you've got 20% kind of coming through the door, already experiencing these symptoms. So just in terms of, I suppose, the diagnosis, and I know this has been discussed in previous presentations, but it's always good to quantify kind of where a patient sits on the growth chart, and sort of classify them into the overweight, very overweight, really obese sort of categories. We use the UK growth charts, but the World Health Organization also has their own kind of growth standards, percentiles, standard deviations. And I suppose these are really good visuals when discussing with families. So it's not just an objective kind of opinion, but actually you can show them that, you know, clinically they meet a certain threshold, you know, for obviously being at risk of your side effects that you get from being overweight or obese. The MUAC scores, I suppose, historically is not something that we would have used as much, but we're definitely trying to use it a bit more often now. Very simple, a tape around the arm, anyone can do it. And then you're just I suppose stratifying those patients into your mild overnutrition or moderate overnutrition at risk categories, using the standard deviations, and obviously the color coding again just makes it really, really simple. And the MUAC is better when you have patients with solid tumors or you know, at risk of fluid overload and things like that. It's a bit more sensitive for the lean muscle mass. Other things that we can look at, sort of a nutrition focused physical exam, the acanthosis nigricans. Basically it's a kind of a dark velvety patch of skin, normally around kind of joints or folds in the skin, so the neck, the armpits, the groin, and is quite a classical sign of obesity. You have your sleep apnea, breathlessness, increased sweating, fatigue, joint mobility issues. But I suppose it's just important to be aware that these can be as a result of kind of side effects of medications, so especially your steroids, insulin resistance, and then your steroid-induced myopathy as well. So just be mindful of this. So the impact of overnutrition short term, I know Peter's obviously kind of already touched on this, but the literature is a little bit conflicting. One large meta-analysis found that the presence of overweight or obesity at diagnosis was associated with an increased risk of mortality and reduced event-free survival in children with ALL, but actually a couple of other studies haven't observed this association. Now, they are a bit older, but one recent prospective cohort study, which was published in JAMA of May this year, which looked at over almost 800 study participants, found that in children with ALL, the more time points they were exposed to being either overweight or obese was associated with the lower outcome survival and event-free survival and higher rates of relapse. So the authors of this study suggested the need to consider interventions to prevent the development of overweight or obesity during treatment. But I think this is an important talking point. Is this appropriate during active treatment? We obviously know it's a problem, but with this kind of trauma and with so much that goes on during active treatment, should we start looking at, I suppose, kind of weight management approaches? So the risk factors for weight gain during treatment, medications obviously a very big one, your steroids, your treatment type, Taste changes, really common. I think most parents who I meet early on into induction report their child has a significant kind of preference for high salty processed foods. They've already got takeaways coming in. Yeah, it seems to impact a lot of kids. A more relaxed parenting style when children are unwell. I suppose parents feel sorry for their kids, and they kind of food is one thing that they can control. So it's less kind of strict around what foods are offered. Parental stress. A lot of parents just absolutely want to avoid the NG at all costs. You force feeding, negative food experience, and the overuse of high calorie options. I suppose the advice that we offer can change very quickly. You might have someone kind of in induction early on who you've spoken to about high protein, high energy, kind of a nutrition support, and then they go home, the steroids kick in, and it's the completely opposite story. They're waking up at kind of early hours of the morning, requesting those kind of high fatty processed foods. So that's very difficult for parents to manage. I suppose prolonged hospital stays, the choice of foods that are available aren't the best, and so it's different, especially when young kids. It's different to what they're used to, and so parents often resort to unfortunately takeaways and things like that. Baseline dietary intake. Kids who are fussy eaters will often struggle then kind of through treatment. You have your behavioral issues as well, often the side effects of steroids, but just makes it harder to implement healthy eating at home. So nutritional considerations when taking steroids. I suppose it's good that parents are aware of the side effects, which can impact nutritional intake and status. So we often see patients presenting with stomach pain or indigestion, increased appetite, waking at nighttime. It interferes with the normal absorption and utilization of nutrients, calcium, potassium, sodium, protein, and some vitamins. Children at high risk of weakened bones and long-term risk of osteoporosis and fractures, increased blood sugar levels, steroid-induced diabetes, difficulty sleeping. So then if you've got poor sleep, research has shown that your choice of food and intake during the day is worse. Kind of reaching for those high calorie foods, I suppose, that you feel might provide more energy. Mood and behavior, myopathy, muscle weakness. Patients aren't able to exercise as much as they used to, while often still eating the same amounts and or more, and then also fluid buildup. So just, I suppose, kind of looking at the particular nutrients. So protein, it's just recommended that patients eat a well-balanced diet, protein source each meal time, meat, fish, eggs, pulses, and then also dairy products as well. So steroids break down the muscle tissue, causing weakness, low resistance to infection, and poor wound healing. For potassium, steroids increase the amount of potassium lost in urine. We recommend, again, you're kind of just going back to your well-balanced diet, 2 sources of potassium. I mean, get a few portions of fruit and veg in there, milk, chicken, yogurt. It's nothing too fancy. It's kind of what a lot of patients would have regularly in their diet. Calcium, steroids can increase the amount of calcium loss in urine, but also cause bone to break down faster, and especially in high doses, which we see in induction. We recommend to increase milk intake of milk and dairy from 3 to 5 servings a day, and also to maintain good calcium intake when off steroids to build up bone mass, and also to consider a calcium supplement if you're worried about intake. Vitamin D just contributes to normal bone, muscle, immune system. Kids are more likely or less likely to be out in the sun, of course, during treatment. So they're kind of at higher risk during the summer months as well. So we just recommend a daily supplement of at least your 10 micrograms or 400 international units a day year round. And there's also some evidence actually to suggest a higher recommendation for children while on steroids. But I suppose best thing to do is just monitor individual vitamin D levels and adjust as necessary. And then sodium can cause food retention and possibly high blood pressure. So the advice is just to limit salt and sodium-rich foods, which, when I go back to the taste changes in food preferences, is obviously quite difficult, especially in the younger kids who you can't explain this to them. So that's hard as well. So just in terms of weight management, the basics. I mean, it's really important to have empathy with these patients, especially when you meet them early in induction. There's a lot going on. and I think a lower capacity to take on a lot of education, and parents really appreciate that they can kind of just take a bit of a step back and breathe, and that, you know, the dietitian or the team aren't coming in, you know, being very strict and you know, having a particular diet that they need to follow, but it's not a free pass by any means. So even with healthy habits, some weight gain is still expected while taking steroids. I think, yeah, parents can just feel a bit more at ease when they hear this. So we'll always just aim to encourage prioritizing a normal, healthy diet, including lean meat and fish, whole grains, complex carbohydrates, and fresh fruit and vegetables, and really just whatever is normal for them. If they can, as much as possible, just limit the amount of refined carbohydrates and highly processed meals and snacks. But this is nothing different to what your regular healthy eating guidelines are. It really is just the same. I'm not going to go through all of these, nothing groundbreaking, very practical, but just, I think, you know, parents are up the walls. I think they really appreciate just kind of really simple take-home advice, which can help manage increased appetite. You know, offer water or low-fat milk instead of sugary drinks. Try and be prepared as possible. Bringing in healthy snacks into the hospital, things like that. So it's always good to have a couple of these on hand. I think they can be really helpful for parents. Yeah, just in times of kind of stress and worry. So the impact of overnutrition then long term. So I know Peter had already mentioned that on average, the percentage of being overweight or obese increases from about 20% at diagnosis to 40% by the end of treatment. Childhood cancer survivors are more likely to die from cardiac causes than the general population. And I suppose kind of these risk factors, CVD, hypertension, dyslipidemia, insulin resistance, and diabetes are, you know, modifiable risk factors. You know, by eating better, exercising more, they can hopefully be managed. So recent data from the Children's Cancer Survival Study suggests that 24-year-old survivor has the same cumulative incidence of severe, disabling, or life-threatening health conditions as a 50-year-old sibling. So I think that just puts into perspective kind of how unwell these patients can be post-treatment. And when you look at the research, nutritional intake in childhood cancer survivors hasn't been adequately examined, but there is more evidence that cancer survivors have a high energy intake, so just eating more energy dense foods and not exercising as much. But that evidence is in comparison to what the current guidelines are, rather than what, you know, your general population is doing. So I don't think everyone is meeting those guidelines by any means, but more research needs to be done in this area, and there's currently no specific dietary guidelines for childhood cancer survivors. We know very little about implementing nutrition interventions or education for survivors and their families, and many survivorship programs don't include weight management, despite these issues being consistently raised. What we do know is promoting a family-based healthy lifestyle is becoming a priority, to hopefully kind of minimize the onset of CVD risk in childhood cancer survivors. And given the risk of both under and overnutrition, so malnutrition in this cohort, I think it's really important the development of guidelines based on the risk stratification, so based on what protocol a child is on and the amount of chemo they're getting, is essential to standardize practice and and to optimize nutrition. But again, more research is needed in the area to examine the impact of current treatment protocols on nutrition related outcomes. Just very quickly, I suppose, just talking about referrals. When you have a patient who is self-referred, a patient or a family, it's only triggered by poor body image. They're aware they've gained weight, and parents are concerned. It's been identified, so that's much easier to approach as a healthcare professional. Because I suppose in terms of behavior change, they've already identified that as a problem, and they're more likely to take on your advice as well. But just when the referral comes from the wider team and it's as a result of maybe a child being identified through a MUAC or a BMI on a growth chart, but it hasn't been discussed with them, I suppose it's just to be mindful of that can lead to very difficult conversations, and just referring back to that behavior change. If the patient has not identified the problem, they're probably less likely to take on the advice. And again, I suppose in this cohort, they're quite stressed. There's a lot going on, it just can make for awkward conversations. So it's always good if you can to kind of start that conversation before having the team to come to review. I just thought this would be interesting. This is our current child and adolescent complex obesity service that we have within CHI. And I suppose just because it's not something that can be fixed overnight, this is very much a long-term issue, and there's lots of kind of moving parts. Within this team, patients have access to endocrinology, nursing, dietetics, physio, psychology, medical social work, occupational therapy, and the treatment lasts anywhere between 12 and 24 months. I suppose highlighting that this is very much a long-term kind of issue, and it does take time. They do group sessions, so weekly exercise sessions, meeting with the dietitian, the psychologist. Parents go on shopping trips. There's cooking demonstrations for the whole family. So it's really, really practical. And I suppose there's a lot of emphasis on promoting like a respectful, empowering atmosphere. You know, like good communication. I think the language that's used is very positive, rather than positive language, and I suppose showing and empowering families that they can achieve a healthy lifestyle if they put their mind to it. So that's all for me. I'm going to pass you over to my colleague.
Thanks, Amanda. Hi, everyone. Great. So I'm just going to, I suppose, build upon what my colleagues have spoken about and just talk a little bit about the psychological factors and implications of overnutrition for our children. So overnutrition is not just behavioural, it reflects a very complex emotional and relational process. And in particular, adolescents with cancer are at greater risk due to that loss of autonomy, emotional dysregulation and impacted coping skills, and disrupted identity development as well. So we know that food can be a real source of comfort, control, coping and connection. So it's so much more than just food. It can be all of those things. And I suppose in our psycho-oncology service here, we work through Professor Anne Kazak's Paediatric preventative psychosocial health model, and we'd find that a lot of children and teens presenting with overnutrition we would see them at that kind of targeted and clinical level, and would require quite a lot of input or support from ourselves. And in clinical psychology, we'd hope to come on board to support with that emotional regulation, to really promote an understanding of why this is happening, and to look at family system dynamics as well, that I've been touched upon. I'll chat a little bit more about now. So thinking first of all, I suppose, just around that life stage of adolescence, and that developmental disruption that happens. So Erikson's psychosocial stages of development, if we look here, we're at that adolescent stage, which is characterized by identity versus role confusion. So really adolescents are at that stage of really seeking independence, you know, really defining their identity, and a cancer diagnosis and treatment can really obviously disrupt and alter that a lot. We find too at that time that peer relationships and independence and body image are all compromised by going through treatment, and beyond that into survivorship. And that diagnosis and treatment can force regression. So we might find that, for example, you know, teens are at a time where they're really striving for that independence, and they are, you know, their treatment can almost force them into increased both physical and emotional dependency on parents again, and a need for dependence and medical compliance. And it's a time when autonomy is developmentally, it's not just strived for, but it's essential as well. So I suppose just thinking a little bit about what food represents. So, you know, it doesn't only signify sustenance or calories, of course, but it can also be really a source of love or care, especially for children and teens post-treatment. It can be a source of self-regulation and managing big emotions that come. It can be a sense of normalcy amid chaos. You know, a lot of the time food and comfort foods can stay the same when everything else is in the midst of a whole new normal, and it can provide that familiarity as well. And we find that family meaning systems around food often shift during cancer treatment and survivorship. So a lot of the time, you know, during treatment, the focus might be on, you know, just getting food in and eating what you can and eating what you want. And, you know, we find that sometimes those patterns understandably can become embedded within the family system and can move on then into survivorship and can be really hard to alter then. You know, and if we're viewing this from a trauma-informed lens, as we always try to do, food behaviours as well may be protective and not pathological. And so may be emotionally very protective for the young person or for the family. So if we think of it a little bit within a cognitive behavioural therapeutic framework, so this here is a CBT formulation. So CBT really recognises that our thoughts, our feelings and behaviours are all intrinsically linked. So this might be, for example, a formulation that we might see for a young person who we're working with. So for example, just for thoughts, a lot of thoughts for young people might come up around loss and control. You know, everything is around me is changing and I can't stop it. I've no control over what's happening, but I can't control what I eat. And food is the only thing that hasn't left me. So food is something that can still be controlled. There's also a lot of thoughts young people might present with around their self-worth and identity. So, you know, I'm not the same person I used to be. We're really being self-critical around appearance and I hate how I look now. There can also be really strong food-related beliefs. So for example, eating helps to distract me from everything else. It helps to soothe me and to regulate. Or that it doesn't matter what I eat. And then there can also be thoughts around helplessness. So what's the point of trying and nothing will get better? And we find that these thoughts can lead into those feelings, you know, of sadness, anxiety or worry, guilt or shame, which is a very, very strong feeling in this context, loneliness, anger, and a sense of grief or loss for what they had imagined their life would be at this stage. And then that can lead into these behaviours, for example, emotionally eating or binge eating for comfort, a real withdrawal from social interactions, fixation on food as a reward or just a sense of escape, and avoiding discussion about eating habits or about weight as well. And I suppose our focus in psychology, it's not just on behaviour change, but it's on a really holistic understanding of the meaning behind the behaviour. And I suppose I'm trying to promote alternative coping mechanisms as well. So just to touch on body image and shame. So a lot of the time, understandably, during treatment, the focus can be on you know, physical recovery, but I suppose there's an onus on us as well to appreciate the differences in body image and just the implications that can have in terms of psychological recovery. So physical changes from treatment, notwithstanding hair loss, weight gain and scars, they can create internalized stigma for young people we're working with. And we know that adolescents are especially sensitive to appearance expectations and to norms. So this can come up in two ways. There can be an internal shame, you know, feeling I'm disgusting, and there can be external shame, for example, that everyone is judging me. And I suppose the reason we really want to focus on shame is because shame and secrecy can often lead into these patterns of either overnutrition or restriction, you know, and this can possibly result in avoidance, secrecy, or being highly self-critical upon oneself. And just to mention here, Paul Gilbert's compassion focused therapy is one particular modality that's really useful to break this cycle. Nowadays, try to use a lot with teenagers, and it's just demonstrated really good outcomes for AYA survivorship populations as well. So to think as well, so we're not, of course, just treating the young person, they're also existing within their family system. So, you know, when we're looking at family systems theory, behaviour is relational. And a lot of the time, a lot of the common dynamics we might see in family is, you know, parents overfeeding as a means of that care and love and affection. And discrepant parenting styles as well. So for example, anxious versus avoidant. So there might be one parent, you know, whose style is to really monitor and then maybe over monitor every single piece that the child is eating, whereas avoidant styles might be a parent who, you know, does not want to engage in discussion around that, so as to not cause distress, especially for a child who's avoidant of talking around that as well. And this can lead to inconsistency or confusion for the young person. And just as I mentioned, there's conflict avoidance through food as well. And also unresolved parental guilt or fear of restriction. So, you know, if there's any parental guilt around diagnosis of treatment, which of course we know that there shouldn't be, but this can result in parents being scared, I suppose, to restrict food and wanting to provide comfort for young people in that way and letting them eat those foods that give them that. So thinking a little bit then about the psychological interventions we might use with young people who are experiencing this. So adolescent and family-centered integrative psychological interventions. So it might not be that one, you know, therapeutic modality covers all of this, but I've just mentioned a few here that we tend to use. So there's cognitive behavioral therapy, narrative therapy, which focuses on meaning making and I suppose retelling of a young person's story. Compassion focused therapy, which encourages a young person to really engage with their soothing system and to find other alternative ways of coping. And acceptance and commitment therapy, which really works with a young person to highlight their values and increase a sense of resilience going into survivorship. So this would all aim to, just for example, explore personal narratives. So what is the story that the young person themselves is telling themselves about illness, food, control and identity? Identifying patterns within CBT, so how, just as we spoke about there, how thoughts, feelings and behaviours reinforce each other and how we can break that cycle a little bit. Reauthoring, so helping teens to cognitively reframe things, so moving from things like I'm out of control to, you know, to having that self-compassion and I'm adjusting to a really hard time as best that I can. We'd also look at promoting meaning making, so exploring identity, values and resilience using acceptance commitment therapy, and developing alternative coping mechanisms, so introducing small acts of choice or expression, you know, being very young person centered, whether that's journaling, music, and helping them to engage in soothing strategies that go beyond food. Just a note as well, just to speak about ambivalence on autonomy. So adolescents in particular, you know, really want to be in control and they may resist change as a form of asserting that control. So taking a relational perspective and working on the therapeutic relationship first is really, really essential, just as Amanda alluded to. It can be really, really difficult, even with a strong relationship with a young person and family, to work on these very sensitive topics. So it's really, really important to slowly build that trust first. And we find motivational interviewing principles can be really helpful with that. So respecting ambivalence and really validating that, and I suppose eliciting change talk and tying goals to personal values are something that's really relevant for the young person. So whether that is, you know, engaging back in a particular fitness class or seeing my friends more by going to different social groups, things like that. So again, just to encapsulate all of that, just taking a trauma-informed view. So, you know, cancer diagnosis and treatment can be a very significant traumatic event in the life of a child or a teenager. And we acknowledge that eating may serve as a means of numbing, distraction, self-soothing, and just having a small bit of control in an unpredictable world. And trauma-informed care prioritises that safety, empowerment, and collaboration. And, you know, in a recent study, it was found that 1 in 3 adolescent cancer survivors experience significant weight-related distress. So it is important, I suppose, to be aware of that and to provide family-centred interventions that help to either prevent or to cope with that. And there's an emphasis too on treatment congruence across the MDT for success. So on that note, you know, practical strategies that can be used across the whole MDT, using really open and non-judgmental language about weight and eating, and just as Amanda spoke about, using that empathic stance as well. Framing conversations around personal values and goals, and using really positive language, for example, you know, having more energy, more confidence, and I suppose what can be gained from working on this. Addressing parental guilt and fear very compassionately and sensitively. And normalizing the links between, you know, emotions and eating, and I suppose that can be done at a team's level as well, that psychoeducation, and using consistent messaging as well across the team so that the family are getting the same message. Okay, so I might move on then, and I'll let my colleagues Erin and Joanne.
You both in? Hi, I'm Joanne. I'm the AOA CNS in Crumlin, Dublin. And I'm Karen. I'm the social worker on the AOA team in Crumlin. And we're just going to look briefly at how overnutrition might come to our attention. And I guess it's been touched on by many members who've already spoken. I guess any member of the MDT may become aware directly or indirectly of suspected overnutrition. So ways that might be directly would be in a direct interaction with the child or with the parent, where you might learn more about if there was a pre-existing concern, or if a child makes a comment about a concern they have, or something that we observe during interaction. And I guess it can also happen at any time point of their treatment journey. So sometimes it's something we might become aware of at the very beginning of treatment, or it could be something that becomes more of an issue in kind of the end of treatment and into survivorship. I guess from a social work perspective, we may become aware of it during contact with the parents and during a psychosocial assessment, where we're like a lot of what Stephanie touched on, where we're trying to learn more about how the family function, what role food plays, and if the parents are reporting kind of concerns or changes in a child's behaviour or practices, and that can come into, as Stephanie touched on, maybe the parental guilt and kind of how they're managing that, or else for us as an AYA team, it could become, we might become aware of it during a heads assessment, which Joanne's going to speak a little bit more about what a heads assessment is and where we use that. Yeah, so as an AYA team, we focus a lot on our heads assessment. It's a key part of our care with adolescents and young adults. It's obviously an acronym, and you can see it over here on the right. So when we meet a patient at the very start of treatment at diagnosis, we would always complete a heads assessment. It's looking holistically at every part of the young person's life, from home, education. Eating is also an important part in that there, and it's more of a newer addition, which I think is really important. Activities, any drug use or alcohol, their sexuality, any suicide or mental health risks, and safety at home as well. So a heads assessment is always done at the start of treatment and at diagnosis, but also at different treatment inflection points. They can be done, at any point, and they're not always formal. So we like to sit down and spend time one-on-one with patients and with their parents as well to go through a heads assessment, but it can really be done through chatting to young people. So while we have an official name for this assessment in heads, it's important to realise that it might not just be us as nurses or social workers, doctors doing this. It could be our household staff, it could be youth support workers, it could be healthcare assistants who are just chatting with the young people and with the patients and parents, and they might identify a red flag or something like that around overnutrition and any concerns. So obviously there is a whole section in this assessment related to eating. Sometimes, as everyone else has touched on, it's kind of a difficult thing to talk about and just delve straight into, eating habits and any concerns about weight and things, especially if you're meeting a young person for the first time. Very often where red flags might come up are things like education. When you ask a young person, what year are you in? Are you studying? Are you going to school? They might say, no, I'm not going to school. So that's very often maybe a bit of a red flag. Similarly, activities, what you do in your spare time. They might say, oh, I do nothing. I just maybe game online and I don't see my friends anymore. So I think that's a good place to flesh out reasons behind those. And very often that will be things like body image, maybe patients after putting on weight or changing in appearance during treatment. So I think the heads assessment is really key to identify some concerns or possible red flags around overnutrition. And as I said, it's kind of important to do it at loads of different points during treatment and be constantly assessing and kind of reassessing young people. From that, I think very often, or for all patients, all adolescents, we will discuss them at our AYA MDM. So we have a weekly MDM where we can discuss all young people with a new diagnosis, but also it's open to bring patients back if we are concerned. So it would be really nice, let's say if the social worker or even the dietitian or anyone who's involved in the care of these patients flags a concern, then we can absolutely discuss or adolescents at any point during their treatment, and then we can refer out and signpost for different supports. So very often what will come from a discussion around maybe overnutrition or body image concerns for one of our young patients would be referrals to our physiotherapy department. Our occupational therapy can be really good as well. So very often, goal setting and timetabling for weeks and things like that is a really good addition from occupational therapy. Who else do we see? Dietitians, of course, and our nutritional team, medical social workers, and then as well as our community supports are really important, I think, for our young patients in tackling overnutrition. So there's some peer support groups, which I think are really important. So I think we have exercise with Canteen, which is like a young person or adolescent group, specifically patients who've had treatment or are on treatment. And very often this will be kind of accessible, or let's say if patients have central lines or have had weight gain or weight loss. These groups are really, really important to signpost our young people to. That said, we also would always encourage them, if they were into sports before, no matter what it is, try to continue going to some sort of light training, or taking on a coaching perspective for when they're on treatment as well, just to keep their foot in the door with exercise, and then it's easier to go back afterwards. Because I think sometimes it's a case of body image concerns when they haven't been to training or their gym or whatever for 6 months or a year when they've been on treatment. It's really nice that they've kept their foot in the door throughout treatment, even from a coaching point of view and things like that. Anything else? I think that's it. So
thank you. Is that the end of your presentation?
Yeah.
Thank you very much, team in Ireland. See if there are any questions. So feel free to pop the questions in the chat, and turn on your cameras if you wish to join in the discussion, or unmute your microphone. Can I ask the team that presented, please, about your the interventions? How many people or how many patients, what's the uptake basically for your CBT, ACT, all the different therapies? What is the uptake like? It's very good that you're offering this.
That's a great question, Mary. Yeah, we generally, so I'm not sure exactly actually, Mary, on numbers at the minute. You know, we would receive a referral from the broader team, and we would always try, I suppose, to link in with an assessment and to support that. So I'm sorry, I don't have an exact change on numbers. I mean, anecdotally, I know oftentimes families are very, very keen for that support, and we're locked into that following an assessment. You know, and oftentimes we'll meet families, I suppose, during treatment. So I'm sorry I can't comment on exact numbers, Mary, I apologise, but you know, typically we would see those kind of, so the way we, I suppose, triage our referrals, they're either universal, priority, or urgent across that CASX model that I mentioned. And so typically those types of referrals might come to us as a priority referral. And usually there is anecdotally good uptake on that, but I'm sorry, we need to look at the numbers.
Don't apologize. Don't apologize. I guess I'm not expecting data, but it'd be interesting for other centers who are here now listening to see whether that, you know, how the referral works. The nurse identify an issue, then refers to psychology, right? And then you then put them, triage it into whichever. So that's a good offering for the service to young people. So may I just ask another question, please? So you mentioned about the guidelines for childhood cancer survivors. There are no, you know, standard guideline at the moment. Would people in this group and yourself in Ireland welcome a group work, just a small task and finish group to work on guidelines? I think nurses would need guidance from dietitians and psychologists to work these guidelines if you are going to develop something. What is your opinion?
Yeah, I think absolutely. I think across the board, centres are doing different things. So it would make absolute sense for guidelines, yeah, to publish. I think with the research that I had read in preparation for this talk, that's what a lot of the reviews had concluded, that guidelines were necessary to standardize care and to make sure you give them the best care possible.
Yeah. So actually the research has concluded that, but nobody has really worked on it. So perhaps either in UK or across Europe, we form a group to look at it. Now, I know there are other groups working on different topics in nutrition, in pediatric cancer. For example, there's one group in SIOP International who is looking at the screen tool and looking at a literature review or which scan tool we use for pediatric cancer. So we can develop something to work on the guidelines, for example. Maybe this is one of our topics that we want to pursue inside of Europe. So please offer any suggestions to Chiara Michi, who can try to redirect the discussions. Can I go back to another question, please, about obesity and the risk of cardiac disease? So obesity in pediatric cancer or young people cancer that might contribute towards cardiac disease. How has anybody done any study or look at the toxicity on the heart, the chemotherapy toxicity on the heart in relation to the actual obesity that's contributing to the cardiac disease? Sorry, I don't know what the question is. Round and round.
Yeah, I might try and, if I understood it correctly. So, you know, a lot of the data in terms of comparing long-term toxicity in survivors of childhood cancer is often comparing patients against healthy siblings or matched populations in some way. And you're comparing what kind of longer-term health problems they may have versus someone who didn't have the treatment and diagnosis that they had. I am not aware off the top of my head if the data is there that pulls out the nuance, specifically looking at the impact of weight gain during treatment on the outcome, you know, independent of things like anthracycline use or, you know, radiation to the chest, for example, both of which we know would impact on long-term cardiac morbidity as well. You would imagine that it's a cumulative effect. We know that people who never had cancer or never had cancer treatment, if they are meeting the criteria for obesity, are at increased risk of long-term cardiac side effects. And you would think that a young person who has additional risk factors for cardiac toxicity, such as from their treatment, that would only be increasing that risk. But I think it's an interesting question about, can we specifically talk about the impact of the weight change on treatment alone? I'm not sure.
Yeah, open for discussion, because there's many more projects we can do together collaboratively. So I'm going to share the survey link. Anybody has any more questions for the presenting group, or anybody in this group would like to add something for discussion? It's been very interesting talk, because we talk about malnutrition and, you know, screening patients, etc., but never thought about the effects of the treatment and the cause of obesity or overnutrition. So that's a very interesting talk, and I thank you for contributing to this. So I'm going to share this screen.